All right, today we're jumping into a really critical topic in trauma management, open fractures. Now, these are a true orthopedic emergency, and for one simple reason. The bone is communicating with the outside world, and that, as you'll see, brings a whole host of immediate and pretty severe risks.
So here's how we're going to break this down. First, we'll nail down the definition and the core risks that come with it. Then we'll get into the absolute cornerstone of classification, the Gustillo-Andersen system. After that, we'll walk through the initial management protocol, then the definitive surgical treatment, and we'll wrap it all up with a look at reconstruction and the key principles that guide everything we do.
Okay, let's kick things off by getting right to the heart of it. What exactly are we dealing with, and why does it command our immediate attention?
The definition itself seems pretty simple, right? It's a broken bone with a break in the skin. But that last part, communication with the external environment, that is the game changer. It's not just a broken bone anymore. It's a breach of the body's sterile barrier. And that single fact completely alters the entire course of treatment.
So why is this breach so dangerous? Well, it unleashes three immediate threats. First and foremost, infection. That wound is a wide open door for bacteria, including some really nasty anaerobes like Clostridium tetani, which is why tetanus prophylaxis is absolutely non-negotiable. Second, you have the severe damage to all the surrounding soft tissues, the muscles, the nerves, the vessels. And all this means that fractures in areas with very little soft tissue padding, like the tibia, become especially dangerous.
So, with injuries this complex, we can't just wing it. We need a system, a way to grade the severity so we know what we're up against. And that brings us to the gold standard, the Gustillo-Andersen classification.
Okay, take a look at this table. You can really see how the severity just ramps up. A grade 1, that's your best case scenario. A small clean wound, less than a centimeter, usually from the inside out. Then grade 2, the wound is bigger, there's more direct trauma, more soft tissue damage. But the real jump, the big one, happens when you hit grade 3. This means severe soft tissue damage. And the subtypes here are crucial. 3A means you still have adequate periosteal coverage on the bone. 3B is a whole other level. We're talking periosteal stripping and massive contamination. And finally, 3C, well, that's defined by an arterial injury that needs repair no matter what the soft tissue looks like. That's a limb-threatening injury.
So we have this really detailed classification system. But you might be wondering, why is this so indispensable? Why do we have to know this inside and out?
Because this isn't just an academic exercise. The Gustillo-Andersen grade is literally our clinical roadmap. It tells us everything: which antibiotics to use, how we're going to surgically stabilize that fracture, what the risk of infection is, and frankly, what the patient's long-term prognosis is going to be. It dictates the entire plan.
Okay, with that framework locked in, let's talk about the first moves. What's the immediate protocol, either on the scene or as soon as the patient hits the emergency departments?
Before that patient even sees an operating room, two actions are paramount. Number 1, immediately reposition the limb back into its anatomical axis. Number 2, get some temporary fixation on there and cover the wound with a sterile dressing. Now, these are not just comfort measures. These are critical interventions to stop a bad injury from getting catastrophically worse.
And this right here is the why. Repositioning isn't just to make the limb look better. When you realign it, you're immediately taking tension off the surrounding soft tissues. And most importantly, you're decompressing and protecting those vital nerves and blood vessels from being stretched, torn, or even cut by sharp bone fragments. It's a limb-saving maneuver. Okay, the patient is stabilized and in the hospital. Now we shift gears from damage control to the main event, definitive surgical treatment. This is where the real battle against infection and for stability is won or lost.
The in-hospital protocol really stands on three pillars. First, the medical side. Get the tetanus prophylaxis and the right IV antibiotics on board. Second, and this is the absolute cornerstone of treatment, perform a thorough surgical revision. You might hear some old-timers call it a toilet, but we're talking about a radical debridement. And third, achieve definitive stabilization of that fracture.
Now let's be crystal clear about what surgical revision actually means. This is not a gentle cleanup. This is an aggressive procedure. We're talking about liters and liters of irrigation to wash out every bit of contamination, and then, critically, the radical excision of all avital, all dead tissue until you get down to healthy, bleeding bone. And while you're in there, you are carefully evaluating every major nerve and vessel.
So, how do we stabilize it? Well, this is where that Gustillo-Andersen grade comes right back into play. For the lower grade I and II injuries, an intramedullary nail or maybe an external fixator is preferred. Notice that plating is pretty much off the table, too much risk of infection.
But for those severe grade 3 injuries, the strategy changes completely. The initial go-to is almost always an external fixator. Why? Because it provides rock-solid stability while still giving us access to that devastated soft tissue envelope for wound care. It's the first step in what's usually a long-stage treatment plan.
After that initial stabilization, the focus shifts to the long game. Now we're talking about reconstruction and the overarching principles that are going to guide us to a successful outcome.
The reconstructive ladder, as it's often called, for these severe injuries is complex. We might be looking at covering huge skin defects with muscle or skin flaps. Eventually, we'll convert that temporary external fixator to a more permanent internal fixation. Sometimes it'll require specialized neurosurgery or vascular surgery. In very rare cases, replantation is an option. And you always have to remember, amputation is on that ladder. Sometimes it's a life-saving procedure, and sometimes it's actually the best path back to function.
We've covered a ton of ground here, from classification all the way to complex surgery. But if you walk away with just one single overriding principle from all of this, what should it be?
It all boils down to this. This is the key takeaway. The single most important principle is the aggressive prevention of infection. And how do we do that? First, with timely and radical surgical debridement to get rid of every contaminant and every bit of dead tissue. And second, by achieving stable fixation of the bone. Everything else we do is built on that foundation. If you get the debridement and the stabilization right, you give that patient the absolute best shot at a good outcome.